a board-certified OBGYN physician with over 30 years of clinical experience. And today we're going to talk about antenatal testing. Antenatal testing is to assess the well-being of the baby for someone who's got a higher risk pregnancy. So you may hear terms like NST, non-stress test, or CST, contraction stress test, or BPP, biophysical profile, or fetal Dopplers, or AFI, amniotic fluid index. These are some of the ways that high-risk obstetricians use, some of the techniques they use to assess the well-being of the baby and to monitor on a more regular basis, either weekly or bi-weekly, for patients who have high-risk problems. Well, what are some of the high-risk problems? Well, there are many of the other videos that I've listed before where you hear about these, but if you have a blood pressure issue in pregnancy, or if you have diabetes of pregnancy, or you have type 2 diabetes beforehand, or type 1 diabetes, or if you have a weight issue, if you're overweight, or if you have a growth issue, if the baby isn't growing well, that's called fetal growth restriction, or it used to be called IUGR, intrauterine growth restriction. So these are some of the criteria where we would measure. There are many other less common higher risk circumstances where this type of monitoring is warranted if you're over 35, so advanced maternal age. But let's kind of dive into some of these. The most commonly used is the NST, non-stress test. That's where you get on a monitor and we track the fetal heart rate in a tracing that looks like kind of like an EKG. So the fetal heart rate tracing and also monitors for contractions allows us to look for what's called a reactive NST. That's a reassuring fetal heart rate tracing that has certain characteristics of the heartbeat with acceleration. So the normal heart has some variance, and the pattern helps us get reassured. The origins of this test was years ago, we found that women who went overdue had a higher chance of complications, or even walking in when they were well overdue with a baby that had passed away. And they learned over time to watch for patterns and discovered that women who were overdue had a higher chance of this, but as long as they had a normal reactive NST that followed these certain patterns, that the chance that the baby would still be alive and well in a week was very high. And there were other indicators like decelerations, especially late decelerations, which occur after contractions, or more variables, or not enough variability. All terms about the patterns. You don't need to know those details, but you're welcome to ask your provider for more details if you're undergoing that indicate that the baby is doing okay, or that it might be in trouble. Also, a normal functioning baby is urinating, and that's where some of the amniotic fluid comes from. It also comes from the placenta, and a normal blood flow from the mom through the placenta to the cord produces enough fluid. So if the fluid is low, that's called oligohydramnios, low fluid, and can indicate compromise and problems for the baby. Depending on when that occurs, that might in and of itself be an indication for delivery. There's also too much fluid called polyhydramnios, a different circumstance, but that's another thing. And then there's something called a biophysical profile, BPP, and that includes ultrasound assessments of the baby's movements, of its tone, whether it's arms are laid out, whether it has muscle tone or it's got tone, whether it's doing breathing movements, which you can see where the chest is expanding. The baby's practicing breathing in there because it's not breathing, it's underwater. You as the mom are breathing for the baby, and your oxygenated blood is going through the umbilical cord, but as soon as the baby's born, it needs to breathe, and so it's practicing developing those muscles, and that's an indicator of well-being. And so that's breathing, tone, the amniotic fluid index, and movement, okay? And then linked to the non-stress test, that's a score of 10 out of 10, or without the non-stress test, 8 out of 8. If the score is lower, it says the baby might need further follow up. If it's low enough, it might be an indication that says, okay, it's time to get this baby delivered. Another assessment test for the baby, for the fetal well-being, is the Doppler test, and that looks for the blood flow in the cord, and the blood goes in both directions in the arteries and veins, one direction in the artery, one in the vein, supplying oxygenated blood to the baby and bringing back blood that doesn't have oxygen in it. And we can watch that flow and the way the blood flows in the umbilical cord and get an assessment of how much the baby's doing, how well it's doing, whether it's getting enough, whether there's problems with it not getting enough nutrients and oxygen, and not growing as well. And those can be used to make determinations on when the baby needs to be delivered. So we've looked at the non-stress test, the biophysical profile, the amniotic fluid index, fetal Dopplers. There's something called a contraction stress test. So you hear non-stress test, the stress is contractions, okay? So non-stress test means we're not having any contractions. A contraction stress test was used a lot more. It still can be used, we don't use it as much because we rely more on Dopplers, but it's available as a test. And what that would be to assess the baby's well-being by giving some medicine called Pitocin, causing contractions, and see how the baby responds to the contractions. If the baby's heart rate shows that it's not doing well or getting what's called late decelerations, that would be a positive contraction stress test, also called an oxytocin challenge test, and that would be an indication for a C-section, depending on the circumstance. So basically, all of these tests put together are ways for us to assess the well-being of the baby and decide, is the baby better off inside or outside? We know the abilities of the placenta and the mom to nourish and grow the baby. We know the abilities of the NICU, and we balance those and come up with a plan on when to deal with certain problems. For example, blood pressure problems, or gestational hypertension, or preeclampsia, are progressive problems that worsen over time. And if you see those videos, you can see that generally speaking, we recommend delivery at 37 weeks for gestational hypertension, or after 34 weeks for severe features, severe preeclampsia, but it might need to be earlier depending on all of these measurements. The take-home message is simply that we are armed with many different tools to assess the well-being of the baby, and they're used to be able to decide how and when to intervene. So hopefully you found this information of use in your particular circumstance. You want to clarify, ask questions on what's going on with you, what the plan is, and your obstetrician, generally a high-risk obstetrician, will be guiding you through this if you're needing any of these tests. I hope you found it of use. Please leave your comments. Thank you.